Fabio,
Yes,
Heather says there are 22 people waiting. So, do you see the people now?
I see 20, yeah, 25.
Okay, so it looks like we might be ready to go, right?
Yeah.
So you can see me,
Yes.
but someone's saying they can't see me.
Yeah, now I can see you.
You can.
Yeah, I can.
Okay, well, I'm not going to change my name now, but I don't see anybody else. Did you start?
Yeah, I would like to share my screen with my slides, but it seems that, okay,
Here you
that,
go.
yeah, at the moment I cannot.
Try now.
Okay. Okay. Oh, let's see, should be this one. Okay. Okay. Can you see my screen?
I can.
Okay, great. So yeah, can I start?
I think so.
Okay. So welcome everyone. Thank you for inviting me this webinar about the the impact of nursing diagnosis on outcomes. My name is Fabio D'Agostino. I am an associate professor at San Camillo's International University of Health Sciences in Rome, Italy. And today I'm going to talk about the impact of nursing diagnosis on outcomes. So let's start with an introduction on standard nursing terminology, and then I'll present several studies that my team and I conducted to test the association between nursing diagnosis and patient outcomes. So as you know, 7 standard nursing terminologies are recognized by the American Nurses Associations. And these standard nursing terminologies were designed specifically for nursing and have been adopted into practice to represent terms such as nursing diagnosis, intervention, and outcomes. These are also called interface terminologies. That means that they can be used at the point of care and include the actual terms used by nurses for describing and documenting the care of patients. We also have some terminologies that are called reference terminologies, such as LOINC as NOMED CT. And also we have a group of these terms that are grouped in a minimum data set, like the nursing minimum data set or the nursing management data set. All of them, all of different nursing terminologies, they all include the nursing diagnosis, of course, except NIC and NOC, but all the other terminologies, they include as terms the nursing diagnosis. According to literature reviews, the most studied terminologies were NANDA International, NIC, NOC, OMA system, and ICMP, as they were implemented at the point of care with documentation in paper-based medical records or especially EHRs at the current time. And in the last 10, 15 years, there was an increase in studies focusing on the analysis of standard nursing terminologies to understand patient outcomes. And these studies describe the association between nursing interventions and patient outcomes, while others focus on developing predictive models. However, although these literature reviews provide an overview of the state of art of standard nursing terminologies, and they were more focused on study methods than study results. Also, in the nursing community, there is an ongoing debate about the utility of using standard nursing terminologies in clinical practice. Still happens, it happens, for example, in my country, in Italy, and I think also all over the world. And I was also personally involved in a project to develop a clinical nurse information system that utilize standard nursing terminology. So 9 years ago, we conducted a systematic literature review to investigate the impact of nursing diagnosis on patient and organizational outcomes in any field of healthcare where nurses were involved. And after applying the inclusion and exclusion criteria, we included a total of 17 studies. In this systematic review also, we rated the quality of the studies using different checklists according to the different study designs. And if a study was evaluated with a poor quality, that meant a score less than 60, these studies were excluded from the literature review. And also we assigned a level of evidence using the Oxford Center for Evidence-Based Medicine criteria. What were the studies that we found? We found 15 studies that were observational. 2 studies had a pre-test and post-test design. 11 studies were performed in a hospital, 5 studies in home care, and 1 study in a primary care setting. As for terminology, most of them use the NANDA International terminology. 1 study used the OMA system, and 1 study used the clinical care classification system. Also, in this literature review, we wanted to check the criteria that were used by nurses to identify the nursing diagnosis. And we found that as for assessment criteria, 9 studies clearly describe the assessment criteria that they used. For example, some studies use the defining characteristic of nursing diagnosis that are present in NANDA International, or specific instruments that were designed for that type of diagnosis to be assessed. While in 8 studies, the assessment criteria were just generically mentioned. As for reliability of nursing diagnosis identification, we found that 8 studies clearly evaluated the nurses' agreement in making nursing diagnosis. Another thing that we wanted to check was the criteria that they used to analyze the nursing diagnosis. And we found that 6 studies consider only the nursing diagnosis identified on patient admission in the hospital or at the time of the first home visit. And 1 study included all the nursing diagnoses identified during the entire hospital stay or home care process. While as for the modality of nursing diagnosis processing, 14 studies analyzed the predicting power of the overall number of nursing diagnoses assigned to the patients for their explored outcomes, while 3 studies considered the effectiveness of using nursing diagnosis jointly with nursing intervention, such as the NIC interventions. We found that these studies explored the association between nursing diagnosis and 8 different outcomes, where hospital length of stay was the outcome most studied. Also, the amount of nursing care was another outcome that was quite well explored in these studies, and also the hospital mortality. As for the level of evidence, as you can see, we assigned there were different levels of evidence in these studies. And in summary, what we found? We found that nursing diagnoses were found to predict patients such as quality of life, mortality, and organizational outcomes such as hospital length of stay, hospital charges, amount of nursing care, and discharge dispositions. Moreover, patient care plans based on nursing diagnosis improve sleep quality, quality of life, and glycemic control. And when nursing diagnoses were added to information from disease-based classification systems, nursing diagnosis improved the predictions of the above outcomes. However, we have to highlight that there was a paucity of high-quality research about the impact of nursing diagnosis on these outcomes. And the results of the selected studies also were hard to compare because of several methodological inconsistencies. However, despite these limitations, we found that nursing diagnoses have a great potential to be an independent predictor for several patient and organizational outcomes. So with the results of this literature review, as we were in a phase to develop a clinical nurse information system, we used these results to convince stakeholders that the clinical nurse information system that we were developing was the way to go. And finally, after implementing this clinical nurse information system in a large hospital in Rome, we were able to collect our data and test these predictions using nursing diagnosis in our setting. And so we conducted this study to investigate if the number of nursing diagnoses on hospital admission was an independent predictor of the hospital length of stay. We conducted a prospective observational study. We included the 4 inpatient units, 2 surgical and 2 medical of the Gemelli Hospital in Rome, that is a large hospital in Rome. And data were collecting using the clinical nurse information system that we developed and the hospital discharge register for 6 months in 2014. We used up to 44 nursing diagnoses according to NANDA International taxonomy, since in that system we use this number of nursing diagnoses, even if nurses had the possibility to record also other nursing diagnoses. We use the nursing diagnosis identified on admission, so within the first 24 hours after patient admission in the hospital. And we conducted 2 regression analyses to investigate if the number of nursing diagnoses was an independent predictor of length of stay. And another outcome was the length of stay deviation, that is the difference between the sample hospital stay and the DRG-specific national average length of hospital stay. And we did this regression analysis after controlling for several variables, such as social-demographic characteristics, clinical variables such as disease groupers, disease severity morbidity indexes, and organizational hospital variables such as admitting inpatient unit and the modality of admission. We had a sample of 2,200 patients. The mean age of the sample was 62 years. Most of these patients were male, and the mean number of nursing diagnoses was 4.3. The mean length of stay was 7.4 days, and the mean length of stay deviation was minus 1.3 days. In the table on the right, you can see also the 10 most prevalent nursing diagnoses that we identified in this sample. This is the first regression model on which we wanted to predict the hospital length of stay. This model explains 33 of the variants. And this is the second model in which we wanted to predict the length of stay deviation. And basically what we found that the number of nursing diagnoses was an independent predictor of hospital length of stay. and this control for patients' socio-demographic clinical variables and hospital organizational variables. And moreover, the number of nursing diagnoses was an independent predictor of the difference between the effective patient's hospital stay and the DRG-specific expected hospital length of stay in Italy. And this result is consistent with previous studies conducted in different hospital population in North America and in Europe. Especially, it was really interesting to see that for the first time, nursing diagnoses were also predictors of a length of stay longer than expected according to the DRG. And indeed, the nursing diagnosis stood out as one of the most important predictors of a length of stay longer than expected. And this finding is very important because a length of stay longer than expected can cause an increase in the use of resources and cost. And we know this as nurses because nursing diagnoses describe patients' health responses and experiences, and this nursing perspective adds substantially to predicting hospital length of stay and so also hospital costs. Luckily, we had the opportunity to test these associations also in another setting. And this is why a first version of the clinical nurse information system that we implemented in the hospital was already available in a community nursing-led unit. And so here, the aim was to identify predictive factors affecting the exceeding of the threshold of the acceptable length of stay established in a community nursing-led unit. Here we conducted a prospective observational study. This community nursing-led unit was located in Rome, in Italy. And the data in this case were collected using the EHR for 7 years. And here we had the possibility to use basically, I suppose, all the nursing diagnoses at that time that were up to 172 nursing diagnoses according to the NANDA International taxonomy. And even in this case, we use nursing diagnoses identified on admission. We conducted here a stepwise logistic regression model to identify which factors among age, gender, marital status, modality of admission, modality of discharge, the Charlson Comorbidity Index, the APR-DRG severity of illness, the Bartle Index on admission, and the total number and the type of nursing diagnosis on admission. And in this case, we use also the nursing activities adjusted for length of stay. And which one of these variables basically affected the exceeding of the acceptable length of stay threshold that for that community nursing-led unit was established that should not be longer than 20 days. Here we had a sample of 900 patients. The mean age of the sample was 78 years old. Most of them were female. And the mean number of nursing diagnoses on admission was 7. And the mean length of stay was 18 days. And 37% of the patient had a length of stay longer than 20 days. In the table, as you can see the 10 most prevalent nursing diagnoses. In this table, you can see the regression model that we developed and the different predictors with their p-value. And basically, what we found here, first of all, here we found that the number of nursing diagnoses was an independent predictor for length of stay in a nursing-led unit. And to our knowledge, this was the first study reporting this. And patients with a higher number of nursing diagnoses, and so with a higher nursing complexity, needed a longer community nursing-led unit stay. As we know, each nursing diagnosis describes a specific clinical condition, and so this may have influenced length of stay in a different way. Also, interestingly, we found that two specific nursing diagnoses, that is impaired urinary elimination and impaired memory, independently predicted a prolonged length of stay. And this result is also similar to an American study conducted in a hospital setting. And as we can see, these two nursing diagnoses clearly refer to the patient's functional status that is considered a determinant of frailty and a predictor of healthcare services use. We also found that 3 nursing activities were significantly related to length of stay. And this is not surprising because variables related to the medical condition did not affect the length of stay threshold. Indeed, this length of stay threshold was predicted by the combination of social resources, nursing complexity, and functional status, as described by nursing diagnosis and by nursing activities, but not by the medical condition. So in this case, we were able to show that the standard nursing terminologies represented the care and the potential of care of that nursing-led unit, and that the medical and nursing needs of the community nursing-led unit population are also very different from those of the hospitalized acute patients. Indeed, we found different type of nursing diagnosis and different types also of nursing interventions between the two different settings. And of course, using standard nursing terminologies, you can show the difference. Now, going back to the hospital setting, we also wanted to test the association between nursing diagnosis and another important hospital outcome, that is mortality. And so we wanted to explore the independent predictive power of nursing diagnosis on patient hospital mortality and to investigate if the inclusion of this variable, in addition to medical diagnostic data, can enhance the performance of risk adjustment tools. Even in this case, we performed a prospective observational study. We included 4 inpatient units of the same hospital, and now you already know, and data were collected with the same tools that I described before for the hospital setting. The same, we use up to 44 nursing diagnoses, and even in this case, we use the nursing diagnosis identified on admission to express the nursing dependency index, that is an index that was already developed by an American study in the 80s. In this study, we used 8 logistic regression models to predict patient mortality by adding to a first basic model that consider patient age, sex, and modality of hospital admission, and also the level of comorbidity. We added at this model the nursing and medical condition as expressed by the nursing dependency index and the APR-DRG weight, respectively. In this case, we had a sample of 2,300 patients. The mean age of the sample was 63 years. Most of them were male. And the mean nursing dependency index was 4.5, and the mortality rate was 4% for that population. In this table, you can see the 8 regression models that were used to predict patient mortality. So from a very basic model then to the last model, the 8th model, in which we included all the variables described before. And here we have a summary of the are squared, and the C statistics, that is a metric to use the performance of the models that were developed. As you can see, the C statistics increased with the more sophisticated model. So what we found here, we found that nursing diagnosis was an independent predictor of hospital mortality after adjusting for patients' age, sex, modality of hospital admission, level of comorbidity, and medical condition. Each additional point on the nursing dependency index, that meant each additional nursing diagnosis on admission identified by nurses, determine a 1.45 time increase in the odds of hospital mortality. That basically means that the odds for hospital mortality were increased by 45% for each additional nursing diagnosis on admission identified by nurses. Also, we have seen that the explained variance of the multivariate models improved when nursing data were considered in addition to medical data, with the performance of the logistic model becoming highly accurate in predicting mortality. And similarly to previous studies conducted in the US, especially in the 90s, the number of nursing diagnoses on hospital admission controlled for medical and social-demographic data was an independent predictor of mortality in a population of medical and surgical patients. Moreover, in both studies, the joint use of medical and nursing data was more accurate in predicting mortality than the use of either type of data alone. And so the nursing diagnosis collected on admission can serve as a prognostic factor, contributing to identify patients at higher dependency and a higher risk for death. And especially it's important to note that the strength of the nursing dependency index is that this index identifies mortality risk before death in models without medical data, because this index is collected on patient admission. And conversely, routinely collected medical data, such as the APR-DRG and the Charson Comorbidity Index, are scored after patient death, and so have no value as an early prognostic factor. Finally, last year, we wanted to test a new hospital outcome with this association, and we presented a new study at the Big Data Science Conference in Minneapolis. Here, we wanted to develop a model by using patient information captured in the electronic health records to predict length of stay, and the new outcome was patient transfer to the intensive care unit, and to test if nursing-generated data collected on patient admission, and basically for nursing-generated data, also in this case, we consider nursing diagnosis, were independent predictors of those outcomes. Even in this case, we conducted a retrospective study, but in this case, we included all surgical inpatients consecutively admitted to that hospital and across one solar year. The number, also in this case, we use the number of nursing diagnoses identified on admission. And we developed 6 models of regression analysis and 6 models of logistic regressions analysis. And the independent variables were nursing diagnosis on admission, the APR-DRG's weight, the Charson Comorbidity Index, the modality of hospital admission, age, and the patient age and gender. We had a total of 5,000 surgical inpatients. Their mean age was 60 years. Most of them were female. The mean number of nursing diagnoses on admission was 6.3. The mean length of stay was 8.6 days. And the patient transfer to ICU rate was 25%. In the first table, you can see the stepwise regression models, the 6 regression models that we use to predict length of stay. So from a basic model to a more sophisticated model that is the last one, the 6th. And in table 2, you can see the logistic regression models that we use to predict patient transfer to the intensive care unit. So even in this case, from a basic model to a more complex model that is the last one. And basically what we found here, we found that in all 6 models, all variables were statistically significant predictors of length of stay and patient transfer to ICU. And in relation to length of stay, compared with the base model, the last model, we had, with the addition of nursing diagnosis, increased the explained variance by 22% to 28%. And in relation to patient transfers to ICU, the addition of nursing diagnosis increased the explained variance by 48% to 52%. So nursing diagnosis systematically collected on patient admission should to be an independent predictor of length of stay and patient transfer to ICU. And this was the first time that researchers have considered this association between nursing diagnosis and patient transfer to ICU. Indeed, previous studies have shown that nursing diagnosis have predictive power on length of stay in different healthcare settings, but this was the first time that we test the relationship between nursing diagnosis and the patient transfer to ICU. And also, again, this is the first study, the first time researchers have investigated this relationship across different surgical specialties and over the course of a solar year. So to conclude and to summarize what we have found so far with the studies, we found that the number of nursing diagnoses seems to be a good proxy of the patient's nursing complexity. Length of stay can be longer for patients affected by the same disease, but with a higher nursing complexity, as expressed by the number of nursing diagnoses. Moreover, even mortality and patient transfer to ICU are independently related to medical and nursing conditions. And so the complementary use of medical and nursing data can be very useful in developing predictive tools for outcomes. As well as on the prognostic level, the availability of standard nursing data can have important implications for issues such as funding nursing care, planning adequate nursing resources, and determining nursing contribution to healthcare quality. And not considering such important elements as nursing care can lead to failure in the goal of having an overall description of patient complexity. And nursing care, as we know, cannot be considered implicitly embedded in the medical condition, because nursing and medical diagnosis pursue different goals and involve different application methodologies. Further, high-quality studies are required to explore the relationship between standard nursing terminologies and different outcomes, and especially the external validity of these studies and the reproducibility of the results should be verified by ensuring that the nursing diagnoses are identified using consistent criteria, and especially that these criteria have been adopted consistently by nurses. Moreover, it should be considered that different nursing diagnoses may be related to different levels of patient case complexity. And indeed, it is very important that additional studies will determine which nursing diagnoses are the most reliable predictors of specific outcomes, so that we can assign specific weights to single nursing diagnosis or to nursing diagnosis clusters in terms of their impact on outcomes, but also to have an idea of the weights that these nursing diagnoses can also have on the nursing work, on the daily nursing work. So future challenges for research should consider the standardization of a method for collecting data, making wider list of nursing diagnoses in EHRs available, and establishing the timing for the identification of nursing diagnoses. For example, if you want to use nursing diagnosis identified on admission and or the nursing diagnosis identified during the entire hospital stay may be also assigned to this nursing diagnosis a specific weight. Moreover, based on the number or the pattern of nursing diagnoses identified on admission, different care strategies could be tested to assess the possibility of preventing patient risk of mortality as predicted by the level of nursing dependency. And I want to conclude with something that is really interesting because this is something that is already in place in some parts of the world. And indeed, in Singapore, they were able to implement a nationwide predictive model that provides all public hospitals with a daily list of high-risk patients who require individualized discharge procedures. And very interesting, this list is made by using existing nursing data collected at patient admission. So as you can see, there is a lot of work to do, but possible directions have been identified. And I thank you for your attentions, and I'm open to any questions. Thank you so much.
Fabio, that was fabulous. I'm not sure, but I can see a couple of questions in the chat. One, it says from an unidentified anonymous attendee. And the question is, were the nursing diagnoses analyzed for their validity and applicability to the patients? Is it possible that some were incorrect or others missed?
Yeah, good question. And yeah, in the studies that we have conducted in our hospital, in the Italian hospital, I mean, it's not mine, of course. And yeah, we included a list of 44 nursing diagnoses because before we conducted a literature review and we see what were the most prevalent nursing diagnosis in a medical and surgical setting. And so that's why we included that number of nursing diagnoses. And about the validity and about the possibility that some were incorrect or other missed, of course, there is the possibility that we miss some other nursing diagnoses, even if nurses had the possibility to record also other nursing diagnoses. And in that hospital, it's very important to remark that there is a quality evaluation of the nursing documentation, and there are often quality evaluation on how nurses document their care. And so there is attention about the nursing documentation. And so this should reduce, of course, the invalidity of some nursing diagnosis, even if this is still a possibility.
So along those lines, Fabio, is there a way, when they provide feedback on the quality of the documentation, is that during the provision of care, during the care delivery, or is that an audit of quality after the patient leaves? Is that in the moment?
Yeah, good question. Yeah, it's audit. So it's not made at the moment. It's made
Okay.
yeah uh, over the
And
course
along,
of the year and in specific occasion also because the hospital is recognized by the Joint Commission. So there are
uh-huh.
also yeah.
So, you know, along those lines, we've often talked about how difficult it is for nurses to engage in documentation when they leave school because sometimes it's different in the hospital than what they learned in school. Did you find that the nurses in Gemelli Hospital were trained similarly, or was there something that the hospital did to train them on the documentation system that they were using?
Yeah, good question. So most of the nurses that they work there, often they are nurses that they study also at the university that is located because it's a teaching hospital.
Mm-hmm.
So and they learn about the nursing process. But however, a great prompt to use in the right way the nursing process was the figure of the chief nurse, because in some inpatient units where there was a chief nurse that was very dedicated also to this aspect of the nursing documentation, they made audit after for example, some occasions, and they reinforced. So the chief nurse was really a leader figure that reinforced the right use of the standard language and the right use of nursing diagnosis. So they had a kind of audit for a specific clinical condition. So in that case, it was made during care, basically.
And so the managers are actually, the chief nurses are managers who are a little bit more clinically oriented than management oriented, is that?
Yeah, chief nurses, yes. And also, of course, there was a strong prompt by the nursing direction also for implementing that system and to maintain also because at the beginning it was not easy because it was something that was quite different of what they did before.
There's another comment in the chat from Laura Gligor. I think I hope I pronounced that right. And she asked, was the nursing theory or model used to collect data at the Gemelli Hospital?
Yeah, good question. And they used the assessment made by Major Gordon. To collect data, they had a standardized nursing assessment with different domains, as you know, for example, nutrition, elimination, and so on. And on the basis of that nursing assessment, the system provides some prompts for some nursing diagnosis that could be possible on the basis of the defining characteristics. But in the end, the last choice was always made by nurses.
Interesting, Fabio, you know, as an organization, we have been talking an awful lot about how we should be looking at a more standardized approach to data collection to be sure that we're making good diagnoses or we're accurate in our diagnosis. There have been many different iterations of items that are essential within each of Gordon's functional health patterns. I'm wondering, did you develop that or did you use something that was in the published literature? There have been a few different publications
Yeah,
citing which items should be collected. And I'm not sure we're there yet, but I'm wondering what you used.
yeah, yeah. As framework, we use the Gordon framework, and as for the items to be in this nursing assessment, basically we started from the defining characteristics of the nursing diagnosis. And also with experts, with clinical experts, we try to find the right defining characteristics that could be connected to specific to the 44 nursing diagnoses that were in that system.
Yeah,
And
that's
yeah,
worth some research in and of itself, right?
yeah,
To
yeah,
find,
and yeah, yeah, and I think also that now we have a great possibility with the use of machine learning and artificial intelligence, because we could have a lot of data that are collected daily by nurses during their nursing assessment, and on the basis of this data, we could link this data with nursing diagnosis to see if really they are connected to some nursing diagnosis. So we could, in some ways, to validate this nursing diagnosis even faster, because we could have a large amounts of data every day.
yeah, well, exactly. And the idea is, as people introduce new electronic health records, what are the essential fields for nurses to collect data about? What are the fields that provide the most data to substantiate the validity of a diagnosis?
Yeah.
I'm having trouble. I can see that there are questions populating here and I I think I'm trying my best to be a good moderator here, but I can't seem to answer live, answer live, answer live. Let's see. Can you see them?
Questions?
Can you see any questions?
In the chat, yeah, I can
Yes.
see some questions, yeah.
For some reason, I can't see them anymore. I could see all of those, but now I can't see anymore. So do you want to try and take a few questions?
Okay. So yeah, I see another one from Oscar Gonzalez. In your experience, what recommendation can you offer regarding the investigation of methodological studies for the validity of nursing diagnosis? Yeah, for example, I think that a new methodology can be the use of data that we could have with electronic health records, and maybe we could focus on specific nursing diagnosis and on specific assessment, and have a large amount of data and see if this defining characteristics, signs and symptoms are really connected to the nursing diagnosis that we want to investigate. So this could be something new that we could do with large amount of data and use for the validity of nursing diagnosis.
Okay, so now I can see, could Gordon's model be used in neonatology?
Yeah,
I would
I think so.
actually comment that our CEO and I had the opportunity to use Gordon's functional health patterns in a neonatal intensive care unit. It was certainly a challenge that I embraced many years ago, but it did work. And of course, it involves not only an examination and evaluation of the neonate, but indeed the family unit, the parents and how they live and what their values are. So I would encourage anybody to try to use it in any area. Then someone, Sofo Sen, and I hope I didn't murder the pronunciation of your name. How many nursing assessments are there, and which assessment should be used first in critical care? you want to take that?
Yeah, let's say that there is one big nursing assessment that we use to connect this nursing assessment with nursing diagnosis. And of course, then there are several assessments that are used in that hospital that are linked to specific patient conditions. And some of them are also connected to nursing diagnosis in some sense. For example, let's say if you use a scale to assess the risk of fall or something else. So there is one big one that is the Gordon one, and then several others assessment, and it really depends, I think, also on the hospital where you are.
It would be nice if we had a standardized approach to assessment.
Yeah,
And I appreciate the question about critical care, where often physiological parameters of health are weighted more heavily. But I would not underestimate the degree to which we're trying to get people back to their usual lifestyle, and understanding what that is an important part of what nurses do.
yeah,
I mean, I
yeah,
almost wonder if those items that you put in the record, maybe they are a little bit different in each specialty area, whether it's neonatology or critical care, and
yeah,
how could we validate what are the essential elements?
yeah, yeah. And indeed, also another development, it should be to create clinical nurse information systems um, that are specific to specific condition, because often we have an overlap between the different assessments, and so we collect basically the same data in different parts. And so, for example, we could have one that is specific, for example, for pain, and so we have all the data in that, let's say, in that box. And it's also easier if you want to then to analyze this data, and also especially easier for nurses that they use this and they don't have to go around different assessments.
So it looks like there's somebody who is a paisano, and this is Ignacio Concello. Concello. I don't know
Yeah,
if who was a first-year student and was fascinated and excited by discovering the world of nursing diagnoses and standardized language. I have many questions, but I'll try to keep it short. I'm interested in investing some time in research and deepening my knowledge about the matter. And we are so excited to hear you say that, Ignacio. Of course, there's a big gap between what we learned during class and what is being put into practice at the hospital. Nursing diagnoses are barely used where he is. And which steps should he take or we take? What resources would you suggest for looking at in order to become more knowledgeable about this matter?
yeah, I think, Ignazio, that you are in the right place, because you are a fellow of NANDA. So I think that NANDA International is the right place to be. And yeah, also there are maybe also you, Laura, you can direct him on the right resources, that there are a lot of them developed by NANDA International. Um, and of course, to be more knowledgeable about the matter, if you if you are looking for research, reading articles about nursing diagnosis, so going in databases and just read some articles, and then focus on specific maybe outcomes that you want to associate with nursing diagnosis, and Probably at the beginning you start saying, oh, maybe there isn't so much, but then when you start to search in databases, you find that there is a lot of knowledge outside.
Thank you. That's great. And yes, it is true that we are constantly looking to our organization to provide more resources to support people advancing their knowledge in this area. We are going to take a lot, one of our, the most important areas that we are focusing on is this idea of standardizing an assessment using Gordon's functional health patterns. And so please do check out our website. If you're interested in getting involved in research, we have a research registry where you can express your interest as well as declare your interest in conducting a study and invite others to participate. So I see, Claudia, I know that we have greetings from Austria, Guatemala, Cambodia, and many other places. I'm so grateful to all of you for participating. And Fabio, I'm sorry we had a little bit of a late start here with the technology, but thank you so much for being available. Your expertise is an inspiration to all of us.
Thank you for inviting me, and thank you to everyone for attending this webinar. Thank you so much.
Okay, we'll be in touch. Stay in touch, everybody.
Yeah, thank you. Have a good day. Goodbye.
Bye.